Pradhyumna will be presenting the case, and thank you, Dr. Suresh, the coordinator of this case conference, for giving an opportunity, and welcome all the participants. Uh, I think it should be a very uh, active and discussion, uh, not just yes or no kind of hmm, thing. And also welcome our chairperson and our former HOD, Dr. Sudhir sir, Professor of Psychiatry from MUGA Medical College. Uh, just most of us know about Dr. Sudhir Hebbar sir. He is well-known psychiatrist and psychotherapist. And just for introduction sake, uh, uh, Dr. Sudhir sir has done his, I'm audible, no?
Yes, sir.
Done his MBBS from KMC Manipal, and did his DPM and DN from Nimans, and he's having vast experience and in psychiatry and preferably in psychotherapy. He has done his psychotherapy certified course, certified course from Beck Institute, and I welcome all, and over to Dr. Suresh sir.
Yeah, thank you, sir. Thank you, Sharanabasappa sir, and thank you, Sudhir sir, for agreeing to chair this session. Today we have fourth PG case conference, and we have monthly PG case conference. It's been going on. This is the fourth one, and without wasting much time, we'll start off the program. Over to Pradhyumna.
Yes, sir. Thank you, Anadol, who are present here. Good afternoon to all of you. Myself, Dr. Pradhyumna, third year junior resident from Saptagiri Medical College. And here I'll be presenting a case of Euphoria to Ecstasy, a case of bipolar disorder. I would like to start off with the socio-demographic details of Mr. P, a 21-year-old male, hailing from Tumkur, discontinued his second PUC studies, currently unemployed since around 3 months, is unmarried and lives with parents and elder brother, is from a Kannada speaking family, Hindu by religion, belonging to lower middle socioeconomic class according to modified Kuppuswamy scale. Informants for the current case history being self and parents being adequate in the amount of history provided. The details are Mr. X, a 54-year-old male father, Mrs. Y, the mother, is a 49-year-old female. Both are close in contact, consistent, continuous, concerned, corroborative, and chronological with respect to the history. Thus, they are also reliable. So the chief complaints for today's case is, according to the patient in his own language, ಏನು ಇಲ್ಲ ನಾ ಚೆನ್ನಾಗಿದ್ದೀನಿ ಸುಮ್ಮನೆ ಕರ್ಕೊಂಡು ಬಂದಿದ್ದಾರೆ. But according to attenders, there is easy irritability since 2.5 months, increased sense of self with inappropriate laughing since 2.5 months, increased activity since around 2 to 2.5 months, and suspiciousness since 2 months. The above symptoms were insidious in onset, gradually progressive with precipitating factors. Now, the history of presenting illness, the patient was apparently doing well while he was brought by parents with complaints of easy irritability since around 2.5 months, where patient started scolding his parents with abusive language, which he doesn't usually do for minor matters, and asking for money, and if not given, becomes very argumentative and used to raise his voice scolding them, which gradually changed to throwing household items, breaking them, along with hitting family members with hands, legs, and pushing them. And this, according to the father, tells that this started after interpersonal work-related rifts at his workplace with other colleagues, and he stopped working around 3 months ago, following which such behavior was apparently noticed. So gradually, this irritability was shown with no apparent reason, and he ended up breaking more valuable items like television, incurring a lot of losses for the family. On asking, he blames his parents that they are very provocative and that they did not take care of him through childhood and that his reactions now are justifiable. He also tells that they scold him for using phone for long durations, but the fact is that he bought his phone from his own hard-earned money, and that nobody has the rights to question it. As he
Just
shall
a
use,
minute.
yes, sir. Yes, sir.
Pradyumna, your video, I can't see you.
Should I? Okay, sir. I will turn on the video 1 second. Uh, one. Can you see me now, sir?
Yeah, yeah.
Yeah.
Yes, yes.
Ah, yes, sir. Thank you. So continuing, he told that his phone is bought from his own hard-earned money and that nobody has the rights to question, and he shall do with his phone whatever he wants. He also reportedly gets aggressive, that is physically and verbally, as mentioned before, if they take away his phone. He tells that it is their responsibility to pay him as they have given birth to him, and also tells that he shall kill his parents once he is independent, owing to how harshly they have brought him up, uh, according to him. And patient also had increased smoking of nicotine since the last 2.5 months, with the parents noticed in the form of cigarettes initially, while patient also had a previous regular use of 2 to 3 cigarettes per day. It has increased since the last 2.5 months to around 15 to 20 cigarettes per day, which was kind of drastic, and also including BDs as well. Patient reports that he likes to smokes as he gets relief as he smokes, and he won't reduce smoking, although he tells that he has the ability to stop it anytime he wants. Reports intense urge to smoke and tells that he likes trying newer forms of smoking tobacco, because of which he started BD smoking as well. Tells that he gradually increased the quantity over the last few weeks to obtain similar effects as before. And father tells that this again happened a few days following interpersonal rifts at workplace. And he was observed to be smoking all day instead of working or helping with household chores. And patient asks his parents to get cigarettes, and on not giving him money or not getting him cigarettes would become aggressive, as mentioned before. Parents report that patient has increased sense of self that was observed since around 2 to 2.5 months. He tells that I am everything and I can handle anything and everything. He tells that he is God and also a huge devotee of Lord Hanuman, and has acquired a lot of superpowers after visiting CB Narsim Swami temple a few months ago, after which he also lost all his illnesses that he had, with having a feeling of increased energy to do a lot of things that others can't. He tells that he gets very angry, and that is good, as that will help him become a big rowdy in future, and is ready to go to any extent to become one and make whole of Bangalore his. Tells that he is very important to himself and that he doesn't bother about anybody else, although he wants to become a rowdy to inflict fear on the ones who trouble innocent people. He tells that he has the ability to earn a lot of money by himself and can buy expensive items that he likes, along with also making a lot of donations. Patient tells that all great people are born on second, like Gandhiji, actor Sudeep, and thus even him. He tells that also hates females and gets angry when he sees them, owing to his past girlfriend cheating on him, although he tells that he can get any girl to like him. Attenders complain of inappropriate laughing and talking since 2 months, with irrelevant talking, continuously talking about unrelated things. For instance, Nanu Raja, Ellargu Sarig Martini, and telling things like he's very happy for no apparent reason, but is observed to quickly switch into becoming irritable for no apparent reason, and is planning to go settle alone in Kashi because he does not trust anybody. He is also observed to be very happy while he asks his mother to stop praying to gods, asking her to throw away all the god idols so that he sits in their place. He is also observed to be wandering out of the house multiple times and also walking to and fro when at house, with sudden singing at times. He is observed to be very friendly with strangers, trying to hug them. And also there is complaints of increased appetite since the last 2 months, which his patient is observed to be eating more than before, repeatedly asking his mother to give something or going out and eating. Is also seen eating non-vegetarian food while his household is vegetarian, and even the patient was not having non-vegetarian food until now. Patient tells that there are people who are looking out for him, trying to harm him as he has superpowers, but is not worried as he is ready to face them because of the powers that he has, and also believes that he is able to take care of them single-handedly. Also reports that at times he has observed others talking about him and has also confronted them for the same. These symptoms are all there since around 2 months. There is history of alcohol use which is occasional since 6 years, which is following interpersonal rift before. Last use were 1.5 months ago, and average use is around 30 to 60 ml of hard drinks. No further history was noted about the same. History of police cases in the past in view of fights with people, but currently all resolved and none pending. Sleep was reported to be normal and adequate, and bowel and bladder movements was normal and regular. Self-care was maintained according to parents and patient itself. Now, coming to the negative history, there is no complaints of increased sexual thoughts or reduced need for sleep. No complaints of thoughts being put in his head or taken away or being heard by anybody else. No complaints of hearing of voices in isolation or seeing things that others don't. No complaints of low mood, loss of interest in activities, easy fatigability, crying spells, thoughts to end life. And no complaints of reduced hope on self, feeling helpless about one's own situation or reduced self-worth, and no complaints of fearfulness, feeling of one's own heartbeat, breathlessness, swearing, sweating, fear of impending doom. No complaints of repetitive, unwanted, intrusive thoughts or urge to perform actions to relieve them. No complaints of nausea, vomiting, headache, loose stools, hard stools, blood in vomitus or stools, and no complaints of head injury or history of seizures. Sir, shall I mention typical day or shall we take a break now?
No, you can tell it, and also you complete the past history also, because the past is also very relevant in this case. So you complete the whole thing.
Oh, yes, sir. I will finish until past history and I'll stop at treatment history before taking a break. Okay. Talking about the typical day of the patient, patient gets up from bed at his own time during the day, smokes cigarette outside the house itself after he gets up in the morning, asks for food and eats, asks for money, and if not given, scolds and hits parents and throws and breaks objects, walking to and fro in the house and also outside the house and coming home at his own time, along with irrelevant talking and inappropriate laughter through the day and sudden singing while he's happy, and goes out and comes back at his own time, asks for food and snacks frequently than before, and takes nap midday at times, and tells that he's going to sleep after dinner, but is often observed to be staying up late during the night. Now, coming to the past history, patient is a known case of psychiatric disorder since around 4 years. Started following interpersonal issues. That is, 1 second. Started following interpersonal conflict. That is 4 years ago. That is the breakup with his girlfriend. First episode was characteristic of increased irritability, showing physical and verbal aggression with elated mood at times, with increased sense of self, that is belief of having powers to sustain any injuries, feeling that God would possess him, with increased energy, activity, and irrelevantly increased talking. Along with around 6 such episodes, patient also had around 2 to 3 episodes characterized by observed to be sitting by self, reduced interaction, not going for work, lying down mostly, and with crying spells, along with sleep disturbance and reduced appetite. The latest previous episode was found out to be as similar to the current episode, that is 4 months ago, that is manic. Inter-episodic interval was around 6 months initially, but gradually reduced to around 4 months according to parents. There is history of two past inpatient admissions, first at Spandana hospitals around 3.5 years ago, and at SIMS&RC Saptagiri Medical College 1 year ago. History of nicotine use since 6 years in form of BDs or cigarettes, introduced by peers initially. As mentioned before, 1 to 2 cigarettes per month, per day used, but currently 15 to 20 cigarettes or BDs used per day. History of cannabis use since 6 years ago, for a period of 2 years. It was introduced by peers, gave a relief feeling on first use, with 1 to 2 joints using per week. Later, gradually increased to a use of 1 to 2 joints per day. Patient tells that he would have an increased relief feeling on using it, and he would often meet up with his friends, even during school hours, bunking school hours, to smoke cannabis. And he would often feel irritable and other symptoms on stopping the use. But apparently, he stopped using 2 years ago, but corroborative history for the same is not found. History of self-inflicted injury over left wrist using blade with no intent to lose life around 6 years ago following breakup with girlfriend, tells that it was to relieve his pain and not to lose his life. History of 2 to 3 police cases against him over time since 4 years, with history of physical fights with people, but none currently pending, and further history about the same or documentation not found. History of dengue in childhood recovered with outpatient care itself, that is around 13 years ago. is not a known case of hypertension, type 2 diabetes mellitus, seizure disorder, or thyroid disease. So this is the past history, sir. Treatment history should I mention since 2021? Sir, I can't hear you. Sudhir, sir. Can't hear.
Yeah, finish it. Yes, continue.
Yes, sir. Okay, sir. So the treatment history started since 5 years ago, that is in year 2021. At first episode was taken to Nimhans Hospital, where tablet risperidone was started and gradually increased to a dose of 6 mg in the night, and tablet lithium carbonate 600 mg over divided doses. And attenders report significant improvement during the course of treatment, but records incomplete during that time. Around 2022, 4 years ago, patient was taken to Spandana Hospital and admitted there, during which patient was restarted on risperidone 4 mg in the night, which was gradually tapered down to 3 mg in the night over the course of follow-ups, along with lithium being increased from 600 mg divided doses to 800 mg divided doses per day, along with benzodiazepine, that is clonazepam 0.2 mg in the night, and trioxyphenidil 2 mg in the morning. Patient was compliant to these medications, and significant improvement over the course of illness was seen. But patient was also tried to put on nicotine patch 7 mg once per daily local application, but was not compliant for the same, and however continued smoking. In the year 2023-24, he was admitted at Saptagiri Medical College, and during which a patient was again non-compliant to medications, had stopped medications a few months ago, during which he was restarted on combination of risperidone 4 mg and trioxyphenidil 2 mg, and over the course of the admission and follow-ups, the doses were tapered during the course, owing to the improvement, along with which he was also started on valproate 600 valproate 1000 mg in divided doses, both of which seem to have caused significant improvement in his uh, course. And now this is the life chart, as you can see. Since birth, now significant events are that in 2019, patient attained puberty, and around the same year, first use of substance as well, that is alcohol and nicotine, which was followed by starting of use of cannabis in the form of joints, which continued for a period of 2 years. And following a apparent trigger of interpersonal rift with and breakup with girlfriend, patient had his first episode that was manic, and the medications were started, and over the course apparently had around 6 to 7 episodes of mania and 2 to 3 episodes of depressive episodes. Yes, sir. Should I
Yeah.
tell family history, sir?
No.
Okay, sir.
Yeah. So now the time for queries, any inputs, clarifications from PGs and other staff who are around.
Dr. Pradhyumna, what was the reason for this current episode?
So current episode, according to the parents, they tell that there was a trigger in his workplace situation where they apparently had a fight with his colleagues. According to the company,
How
the
about the
working.
complaints with the medication? Can drug default be a trigger for this episode as well?
Yes, sir, definitely. But according to the parents, he was apparently taking medications regularly, and the rift happened while he was compliant to medication. After which he stopped his job, came home, stopped taking medications, and started apparently showing this irritable behaviors. So, as you can tell, the compliance can also be a significant trigger, as it has been in the previous episodes as well. But currently, the history does not really corroborate saying that the stopping after which the episode occurred. But it is totally possible, sir.
And many of the HOPI had interpersonal rifts. So probably I think using better terminologies would be better,
Okay, sir.
because
Okay, sir.
you used almost more than 5 to 6 times. So it did not convey what exactly it was in HOPA.
Okay, sir. I would.
Better terminologies, yeah.
Yes, sir. I would learn to mention it more specifically.
Yeah.
Yeah, this drug complaints and the reason for relapse, that is very useful information at that point. So any other factors which are known to trigger his episodes, because we have already 3 or 4 episodes of mania in this case.
Yes, sir. Yes, sir.
So anything known factors which trigger his problem, whether it's interpersonal or sleep problem, sleeplessness, like not sleeping.
Hmm.
Some manics, some bipolars. This can be a triggering factor. Life events.
Yes,
So
sir.
skipping medication is one another factor. So in this case, you are saying that medication appears to be was compliant, but still you are adherent. The more better term to use is nowadays is not compliance,
Adherent.
is adherence, drug
Yes, sir.
adherence. So, which are the medicines he was on while he relapsed?
So during this latest episode, he was on risperidone and sodium valproate, sir.
Okay, he was not
Uh,
on lithium.
no, sir. He was, according to history, he was only tried on lithium initially, sir. That was 4 years ago. Later, since his admission in Saptagiri around 2 years ago, he has been on sodium valproate itself.
Yeah. So, and many a times, once the mania appears, the relapse happens, then they stop medicine. That is also possible many a times.
Yes,
It's
sir.
very tricky area to find out what is causing what. Like because of the stopping medicine, he relapsed, or because of the relapse, he stopped medicine. Patient stopped medicine. That becomes a confusing area, gray area usually.
Yes, sir.
Because manic state is a very energizing, and they feel I'm perfectly all right, absolutely.
Yes, sir.
So that itself will trigger them not to take. Both
Mm.
are possible. If you see, even in our ward also, we have one patient with the same issue, like whether the relapse happened while taking medicine, or it appears again here also while taking the valproate only he relapsed again.
Mm. Yes, sir.
Again, this is not very surprising. Like valproate is not uh, like panacea or great medicine. So many people don't respond, or that may not be useful for prevention also.
Mm.
Okay. Any other inputs, queries from PGs
There is one
especially?
question by Dr. Gurraj sir. Did the police cases occur during his manic episodes?
The start of the police cases was around since 4 years, and yes, according to father, they do tell that during the manic episodes, the fight would happen with certain friends or his colleagues, during which the cases would get registered. And but the clear history about it happening between within episodes or during his lucid interval, we don't have that clear history, sir.
Yeah. I have few suggestions and comments.
Yes, sir.
One, because he has been undergoing a legal issues, what is the liability of this individual for any kind of punishments from the legal cell? One. Second, the treatment chart, not treatment chart, the episodes could have been better depicted because there were multiple episodes. The episodes, the chart of those episodes could have been like much better. And regarding the treatment and admissions, probably putting it in a better way, like what was the adequate trial of the dosage was considered. IP care,
Yes,
whether irrespective of the hospital, kind of hospital or a medical college, the kind
yes,
of setup he was in, whether what the adequate dosage was given, whether the patient had any issues related to complaints, could have been in a better way, like for a postgraduate,
yes,
could
sir.
have been in a better mentioned in a better way.
Okay, sir. Thank you, sir. Sir, shall I move further?
Just a minute. Yeah, any PGs have to come out with some comments. They are the main
Yeah.
beneficiaries of this event, so their participation also very much welcome. Even appreciation also, you can tell anything you are
Yes.
happy about the presentation. Yeah. So this aggressive acts, you exactly mentioned what he was doing, like hitting with the hand. You
Yes,
have
sir.
specified all those. That is a good thing.
Thank you,
Many
sir.
times we simply say that patient was aggressive, abusive, assertive, and finish that without
Yes,
elaborating exactly what were the behaviors
yes,
patient has done. And reliability, validity, you have told in a good way.
yes, sir.
And in the complaint section, this, for example, sense of self, increased sense of self, and inappropriate laughter, very unlikely that relatives would have used such sophisticated words like inappropriate laughter, all those things. So,
Yeah.
increased sense of self. These are all our own words naturally.
Mm.
So in presenting complaints, we have to use as much as possible the hardcore words which patients or relatives have used as their complaints.
Okay.
Like,
Okay.
they would have told he is not sleeping, he's angry, he's abusive, all those kind of things he can't handle. Those would have been the complaints from there. Yeah. So there are no questions or clarifications. We can move forward.
Yes, sir. Thank you.
Okay.
Coming to the family history, patient is the second born of a non-consanguineous marriage, born to parents of 54 years father and 49-year mother currently. He has an elder sibling of 25 years of age, is a male, and is an engineer by profession currently, and the patient is 21 years. Breadwinner and decision maker of the family is father. Father is an apartment in charge by profession. Mother is a homemaker. Relationship between parents is good, but frequent fights over the 25 years of married life, that is arranged marriage, mentioned both by parents as well as the patient. And parents' relationship with children is authoritative kind of parenting with some lenience for personal choices, but history of father and mother hitting children until the age of 12 to 14 years of age with hand or stick at times of mischief. And communication is good between patient and parents, but frequent arguments between patient and parents and usually provoked by the patient itself. Relationship with of patient with siblings is questionable as there is history of frequent fights throughout the childhood, mostly provoked by patient, and there is reduced interaction between siblings since the last 2 years. Other than this, there is no significant psychiatric history in family, while there is history of hypertension in father since around 10 to 15 years of this thing on treatment currently. There is no significant stressors noted from the side of the family. Personal history. Birth and development, there is full-term normal vaginal delivery, uneventful, prenatal, national, and postnatal periods, and developmental milestones attained according to appropriate age groups. Behavior during childhood is a patient through temper tantrums as a child to fulfill demands and frequent fights with peers and parents and other authoritative figures like teachers, along with truancy, stealing money from father at around class 10. Frequent rifts with parents since 4 to 5 years, along with being disobedient and argumentative with parents, although the relationship is maintained well with some peers. Physical illnesses during childhood, history of dengue at 8 years of age, treatment under OP care, and no other physical illnesses like epilepsy, meningitis, encephalitis. Schooling began and finished schooling at appropriate ages with government school, but one change at fifth standard, where patient felt really uncomfortable gelling with new peers and teachers and took long time to get adjusted during that time. And during that time, patient also observed a lot of truancy and disobedience. Average scholastic performance at school present, along with frequent arguments with peers and teachers, as reported to parents. Patient apparently discontinued second PUC studies following rift with breakup with girlfriend and did not rejoin apparently in view of patient's illness. Occupation, age of starting work is around at 18 years of age. Started with a Toyota company as a mechanic for 4 months duration, after which he changed to a paint delivery personnel for around 2 years, where he would drive and deliver paint boxes to different houses and construction sites. And patient stopped going to work apparently since around 2.5 to 3 months following workplace rift. Patient reports work satisfaction and competence is displayed, but no clarity regarding ambitions and future prospects. Sexual history identifies as a male with age of onset of puberty at 14 years of age, heterosexual orientation and mode of gaining knowledge regarding sex from friends, but further sexual history could not be elicited as patient was not cooperative for the same. Substance use, nicotine, cannabis and alcohol history is present. Now, coming to the pre-morbid personality, social relations, he was dependent on family, maintained good relations with some peers, apart from some interpersonal rifts with physical fights with peers. And he's a follower and aggressive at times, and also argumentative with conversations. Intellectual activities mentions none, but no issues with memory, observation, judgment, and critical faculty. Mood, he tells he is bright and cheerful, and even parents tell that he's sometimes bright and cheerful, but unstable at times, worrying at times, only being calm at times, but also impulsive at many instances. Character, attitude to work and responsibility could not be commented upon as patient hadn't worked before his morbid period. And interpersonal relationships, again, self-confident with them, but sensitive to criticism, frequent fights with peers and authoritative figures in his life, trusting but quick-tempered at times, tactful, enjoyed self-display, expressive but rigid at times. Energy and initiative is energetic, output sustained with irregular fluctuations. No daydreaming reported in fantasy life, and again, habits are substance use, that is tobacco, cannabis, and alcohol. General physical examination, all physical parameters were found to be within normal range with no signs of pylorictus, clubbing sinuses, lymphadenopathy, edema. And owing to his past history of medications of antipsychotic intake or mood stabilizer intake, there was no tremors or rigidity also found. Coming to head-to-toe examination, there is a 2 centimeter scar over his wrist, left wrist, owing to the self-inflicted injury using a blade 4 years ago. And there is a tattoo on his right forearm saying Anjaneya. Systemic examination, cardiovascular system, S1, S2 heard no murmurs. Normal vesicular breath sounds heard on respiratory system, no added sounds. And soft non-tender perabdominal examination with bowel sounds heard and no neurological deficits on central nervous system. Now coming to the mental status examination, general appearance and behavior. Patient is conscious, not cooperative at times, irritable, oriented to time, place, and person. Patient is kempt, maintains eye-to-eye contact, while rapport was established and maintained with difficulty. Inappropriate smiling and laughing at times during the interview, and over familiarity with the interview, for instance, trying to kiss the hand of the interview and trying to hold the interview shoulder with his hands. Hitting parents, throwing items, getting up from bed happened multiple times during the interview, and patient was apparently also demanding for cigarettes from the examiner itself during the interview. While there is no history of tics, mannerisms, or stereotypical movements noticed through the general appearance. Increased psychomotor activity with increased blink rate observed, and spontaneous speech, irrelevant at times, coherent, with increased tone, tempo, and volume of speech, with reduced reaction time. Prosody of the speech was maintained. Thought is a speech sample was taken, recorded, and transcribed using taking consent. It was transcribed verbatim. The neutral topic given was a festival, and the patient spoke about Narsimha Puja. The speech sample goes like this. ನರಸಿಂಹ ಹಬ್ಬಕ್ಕೆ ಊರಲ್ಲಿ ಫೋಟೋಗೆ ಪೂಜೆ ಮಾಡ್ತೀವಿ, ಫೋಟೋ ಕ್ಲೀನ್ ಮಾಡಿ ಪೂಜೆ ಮಾಡ್ತೀವಿ, ಆಮೇಲೆ ಮನೆಗೆ ಬಂದು ಎಲ್ಲ ಊಟ ಮಾಡ್ತೀವಿ. ಮನುಷ್ಯ ಅಂದ್ರೆ ತಪ್ಪು ಸರಿ ಇರಲ್ಲ, ಯಾವುದೇ ಆದ್ರೂ ಕಾರಣ ಇದ್ದೇ ಇರುತ್ತೆ, ಬೇಕಾದ್ರೆ ಹೆಂಗಾದ್ರೂ ಬದುಕ್ಬೋದು, ನಾನು ರೌಡಿಯಾಗಿ ಚೆನ್ನಾಗಿ ದುಡ್ಡು ಮಾಡ್ಬೇಕು, ಚೆನ್ನಾಗಿರ್ಬೇಕು, ನಾನು ಆಂಜನೇಯನ್ ಭಕ್ತ, ಅದಕ್ಕೆ ಮದುವೆ ಆಗಲ್ಲ. From the speech sample, it can be inferred that there is notable tangentiality, accelerated speech, flight of ideas under thought stream, while no abnormality in form of thought. From obtained history until now, it can also be inferred that in thought content, there is increased self-esteem and delusion of grandiosity, owing to him saying that I am like God, I have superpowers, others don't, and I have ability to earn a lot of money. And belief that others are planning to harm him, and belief that others are talking about him, infers that patient has delusion of persecution and delusion of reference, respectively. And patient also reports over religious thoughts like frequent mentions of Hanuman, Narsimha, and other gods. There is cravings for nicotine present, and there is the locus of control for nicotine use is internal with pre-contemplation level of motivation. Mood, he tells in his own words, super agide subjectively, but objectively the affect is dysphoric, which is labile and moves to being exalted over the course of interview with increased range and reactivity, inappropriate to situation, congruent to thought, and communicable. There is no abnormalities in the perceptual field, and insight is 1/6. Now coming to the cognitive functions, sir, can I mention only the positive findings or mention everything? Okay, sir, I will just mention the inferences. He was oriented to time, place, and person. Attention drawn and concentration sustained. Immediate, recent, and remote memory intact. While general intelligence, comprehension, and arithmetic skills were intact. Thinking is also at abstract level. Positive finding is that personal and social judgment were impaired, as while patient was observed when asked about future prospects of his life, he told that he wants to become a rowdy, earn money by any means, and also hits parents and does not bother if something happens to him while harming others. So he's not bothered about the consequences, because of which it is inferred that his personal judgment is impaired. Coming to his ward behavior and other social behavior, he was observed to be throwing things in the ward, troubling other parents with patients with inappropriate behavior, that is using slang words, not bothering about authoritative figures around him, showing that his social judgment is impaired. Now the test judgment was intact, because he was given letter problem and fire problem, and he answered appropriately. And insight, there is no awareness of the illness, so it is 1/6.
Okay,
Coming,
before going to summary, this
yes, sir.
MSc is very important portion. A few minutes we can spend on that.
Yes, sir.
Like any clarifications or doubts or suggestions about MSc items?
There are a few questions in chat box.
Yes, sir.
Yeah, you can.
Dr. Gurraj sir has asked, is it the workplace rifts due to his manic condition that needs to be evaluated? That was missing. And any history of ADHD was not well elaborated with respect to his onset of illness. And most of them have commented that the temperament history would have been better rather than personal history, because the premorbid personality, because the onset of illness was much more earlier. So most of them have asked it would have been temperament history rather than premorbid personality. And one more comment is this: Narsimha Puja is a part of his psychopathology. Because he's claiming that he has extra powers, he has more powers. Giving the same topic for his speech sample would be not a very apt choice.
That's correct. Yeah.
Instead of that, you should have chosen some other neutral topic. Again, psychopathology cannot be a neutral topic. So that's what the people have asked, and this can be can be taken as suggestion from people.
Yeah.
Uh,
And this sample of speech, if you go through 4 or 5 lines you have written, it's a bit shorter. Maybe if it is longer one, it will be still useful. So in that, which one you are saying that whatever you have accelerated speech, you said the flights, you said tangentiality. So for which one was there in that, and which place out of those sentences? Where was the tangentiality? Where was the flight? Accelerated speech in that sample.
Yes, sir. Accelerated speech, owing to the number of words he used per minute, based on the tempo that he used, I was able to say that there was accelerated speech, sir. It was faster than like normal pace that anybody would speak. Apart from the tangentialities, that, sir, he started off saying about what he does for the festival, but then suddenly jumped to something, telling that once he has food, then he suddenly jumped into telling that how ಮನುಷ್ಯರು ಅಂದ್ರೆ ತಪ್ಪು ಸರಿ ಇರಲ್ಲ, and all those things, how it was not at all linked to each other. It was very vague, sir. So
Yeah.
from there he went, and yes, sir.
Is it tangentiality or sudden? What is the word there?
Loosening of association
Yeah, it's
as
a derailment. Actually, derailment. If it is very frequent, like schizophrenia, every alternate sentence will be a derailment. But here, or if you see the context, why he brought that, some other clues were there for him to jump to that topic. That is difficult to decipher from this only record. So we have to see the context also. Many times manics pick up cues, and from there they go to the different topic. So any injustice was happening around there, he would have gone to that topic. So, this is derailment rather than one example. So we can't say whole his speech is derailed or that is prominent thing. So one example of derailment rather than tangentiality is from the beginning itself. Patient starts the answer in a tangential way. That
Yes.
may be the. And flight. What is the flight of idea in this?
So flight of idea, how the subsequent ideas that he mentioned, sir, after,
Yeah.
were very
So
by chance related to each other,
So
sir.
in manic, generally when we use flight of ideas, it is always associated with the rhyming, punning, clang associations,
Hmm.
those kind of pressured speech plus flight of ideas. Manic, we reserve that flight of ideas for manic speech, where we see a lot of rhyming, punning, and clang associations, alliterations. The other way, in Nancy Anderson's TLC, the definition of flight of idea is slightly different. There, both derailment and also manic typical flight of idea.
Yes, sir.
So both are included under that flight of ideas. So this
Yes, sir.
is So here, did you have that flight of idea of clang associations, chance associations? The speech goes by chance associations rather than regular thoughtful
Uh,
associations. Was it there anything like
that
basically rhyming, punning, clanging, those associations led speech?
No, sir.
So
That was not there.
then
Uh,
flight may not be a very appropriate term there.
hmm.
So
Sample
typical
size
many
itself
flight,
is
yeah,
sample size itself is less. That's why we cannot
yeah, very short. So we
make
can't
it
comment much on that. So one occasion of derailment is there. Other than that, there is no much thing in that sample speech. Other place, other MSCs, other time at flight of ideas. That will be many flight of ideas where we need to have those clanging association, ding dong, all those, or rhyming,
Hmm.
punning, like Jagesh kind of speech.
Yes, yes,
So a
right.
lot of fun and playing around with the words.
Yes,
Okay, so yeah, we'll continue then. Carry on with.
yes, sir.
One more comment in chat box by Dr. Subramaniam. Can you
Yes, sir.
please elaborate thought content with the patient's verbatim to establish delusion and its vectors?
Yes, sir. Yes, sir. The delusions mainly the patient had was first is delusion of grandiosity, saying that patient believed
No,
that I am.
actually, in previous case conferences, the examiners had a comment. You should describe the verbatim and then give the inference, rather than giving the inference first and then giving the verbatim. You can make modifications like that.
Okay, okay, sir. Fine.
Yeah.
Patient was saying that I am God, I have superpowers, others don't, and have abilities to earn a lot of money. And this showed that the patient had delusion of grandiosity, while the vectors that were meeting with it, he had complete conviction of the thing, and the bizarreness of the delusions were also quite met. And along with this, because of this belief, there was significant extension and disorganization in his daily life as well. The way he was behaving like he's a god, and then how he did not bother about anybody trying to hit him back, and how he would believe that he will be able to face even somebody who's bigger than him, or more looking more powerful than him. Even the bouncers that came to the ward, he would be very confident to face them. And he would only end up like submitting if we restrain him physically. Even then he would be telling things like, it is not a big thing for me to unrestrain myself and then come and take revenge on you guys. So it is not a big deal. So he would tell like those things. So that is the grandiosity and belief that others are planning to attack harm him. He started off telling that because he has superpowers, since others are not unfair, they would try to harm him because they don't want him to be happy and be existing with all those powers. So they would try to attack him, and he would be very confident that somebody would come to attack him. And he would also not bother, given to his manic congruence. He would not bother about the same thing, and he would think that, oh, yes, I can face them anyway, so it doesn't matter if they're coming. So only the suspicion part was there, but fearfulness for the same was not there. And believe that others are talking about him, he would tell that, of course, I am very different from them. I had superpowers, they will talk about me. It doesn't bother me, but I observed them talking about me and referring to me multiple times.
Okay.
Yes, sir. Thank you.
How
Yes.
much time we have? So we can adjust the discussion.
So we have 20 more minutes, sir.
20 more minutes. Okay, okay.
It's
Good.
2:50. By
Yeah,
3:10 we can wind up, sir.
yeah. Okay.
Yes, sir. I will finish the summary part faster, sir. Case summary: 21-year-old male hailing from Tumkur,
We can go
discontinued.
for even formulation
Yes, sir.
Okay,
directly. Go for formulation, most important technical
fine, sir.
terms
Fine,
we
sir.
can
I
use.
will start with formulation itself. A 21-year-old male studied discontinued at PU level, unemployed since 3 months, unmarried, lives with parents and elder brother, lower middle socioeconomic class, premorbidly quick-tempered, sensitive to criticism, with frequent temper tantrums, frequent fights, truancy, stealing, and frequent fights with authoritative figures, with being disobedient and argumentative, with family history of strict to authoritative parenting, was brought with history of cannabis use in the past around 6 years ago for 2 years, continuous nicotine smoking with occasional alcohol use, with past history of diagnosed bipolar affective disorder type 1 triggered by breakup with girlfriend, started with manic episode first, furthering on to a total of 6 manic episodes and 2 to 3 depressive episodes for the over the course of illness, before being brought currently with complaints of irritability, euphoria, increased activity, expansiveness, increased sense of energy, pressured speech, flight of ideas, increased self-esteem with grandiose delusions, persecutory and referential delusions, with increased appetite and reckless behavior, with mood lability since around 2.5 months, along with increased use of nicotine with cravings, tolerance, novelty seeking, salience, use despite harm, and withdrawal symptoms on reducing or stopping use. MSc was corroborative with symptoms with impaired personal social judgment and insight around 1/6. According to ICD-11, I would like to make a diagnosis of bipolar affective disorder, type 1, current episode manic with psychotic symptoms, that is 6A 60.1, and 6C 41.23, that is, no, sorry, 6C 90.11, that is oppositional defiant disorder without chronic irritability, anger, with typical pro-social emotions. Further evaluation needed for the same, as patient is currently in episode and we are not able to retrospectively find the symptoms. Apart from this, there is 6C48.20 nicotine dependence current use, 6C40.10 harmful pattern use of alcohol episodic, and 6C41.23 cannabis dependence sustained full remission. To aid with my diagnosis, I would like to apply diagnostic scales like Young's Mania Rating Scale, Oppositional Defiant Disorder Rating Scale, and Fagerstrom's Test for Nicotine Dependence, to mention a few, along with some handy supportive scales like BPRS and PAN-SS scale would also be helpful to assess the patient. Now, coming to the management part, I would like to manage the case under IP care, under Mental Health Care Act 2017, Section 89, that is involuntary admission, and supporting my decision are points such as harm to self or others and damage to property, non-compliance to medications history, comorbid psychiatric conditions, that is double diagnosis, and inability to care for self currently. I would like to send for basic blood investigations like CB, complete blood count, liver function test, renal function test with serum electrolytes, and along with ECG and other basic investigations to before starting off any treatment currently. And I would like to pharmacologically manage by starting a short for acute management. I would like to start with a mood stabilizer, and given past evidence of improvement with sodium valproate, and also the fact that sodium valproate is useful, documented useful in case of dysphoric mania, and along with rapid mood lability, I would like to start with sodium valproate for 1500 mg, given the fact that the patient's weight is around 70 kgs and around 25 mg per kg would be the optimum dose of sodium valproate. I would like to start on 1500 mg over divided doses in the day. And to prevent any daytime sedation or afternoon sedation, I would like to keep 500 mg in the morning and 1000 mg in the night. Any antipsychotic that I would start for this would be tablet risperidone, because of past evidence of improvement with risperidone, and also the fact that according to Maudsley's guidelines, risperidone is a treatment of choice for dysphoric mania and manic episodes per se. Although there is good evidence for others like olanzapine, aripiprazole as well, but I would like to go with risperidone owing to past improvement history. So I would like to start with around 4 mg in the night, and plan to alter the dose in line with lines of response. We could like try to taper it, increase or decrease the dose based on that. And I would like to start with triaxiphendyl 2 mg in the morning to prevent any kind of extrapyramidal symptoms that can be a side effect of risperidone itself. And I also like to start on nicotine gums, 4 mg SOS hourly to prevent cravings of nicotine, with plan to taper gradually. So these will be my pharmacological management strategies. Non-pharmacologically, I would like to mention some strategies like psychoeducation, interpersonal social rhythm therapy, which is evidently found to be very useful when it comes to bipolar disorder. Environmental modification, which will also help with modification of environmental cues that are usually found to trigger the patient, and also workplace environment to be optimal for the patient considering the history of this diagnosis, so that it will not help in further trigger of events leading to further episodes. And I would like to also mention cognitive behavioral therapy, which is evidently found to be very efficient when it comes to altering patterns.
We'll cut short a little bit. Anything other than this psychotherapy? Any other things you want to say before?
Yes, sir.
we-
Yes, sir.
Yeah.
So I would like to mention some differential diagnosis for the same. I think it can also be schizoaffective disorder, but negative points in favor is no continuous psychosis or disorganization is found in the patient, and dissocial conduct disorder can be ruled out as the medical legal or police cases are in continuity to the BPID itself and not in separation premorbidly, and no such evidence was found. So dissocial conduct disorder might not be a good choice. And along with this intermittent explosive disorder, if we get more history about his sudden explosive anger outbursts, if that is there. Apart from this, I would like to mention some prognostic factors. The good prognostic factors I could come up with is that only family support and history of improvement in the past. And if anybody in the viewers can come up with more good prognostic factors, I would like the help. And the bad prognostic factors are early age of onset, male gender, which is documented to have poor prognosis according to Kaplan's, and multiple episodes in the past, double diagnosis, that is a mood disorder with a substance use history, comorbid psychiatric disorders like oppositional defiant disorder or any other temperamental issues, personality issues that might be possibly present before occurrence of bipolar disorder itself, and history of depressive episode. Presence of depressive episode itself is a bad prognostic factor when it comes to bipolar prognosis. And history of non-compliance to medication, since it is there, it is also another bad prognostic factor. So again, with the prognostic factors, if anybody could come up with more points, it would be very helpful, because I'm pretty sure that I might have missed out on something.
Okay. Anyone want to comment on the management line of management? Any investigations? What about thyroid? It is done. Thyroid recent.
Thyroid, yeah, yes, sir. Thyroid, again, I forgot to mention, but it's also very important given the fact that
Is
we might
normal
be
or is
thinking.
on thyroid already? Is it
No,
normal?
sir. Is it normal, sir?
Okay.
Doing
Okay.
thyroid.
Yeah. And renal functions also.
Yes, sir. Renal function.
And in the ward stay for initial 3 days, you are not ready to take the medication. We are given injectables, and for 3 days, we are given Sharanase 10
Haloperidol.
mg and this that is haloperidol and promethazine 50 mg for week, and twice daily. After 3 days, we have switched over to the oral medications, and
Yeah. So how much
smoking part.
Sir,
this Respiridone? How much you are giving?
so risperidone
How,
4 mg started currently, sir, tablet. I would like to taper, increase or decrease dose based on the patient's response and aggression and psychotic behavior, how it changes. I would like to see.
yeah. So anybody want to favor lithium over valproate in this case? Anybody for that? Voters for lithium in this case? So how about if you discuss like pros and cons of lithium over valproate in this case?
Sir, again, classic mania, if that was the case, like euphoric mania was predominant, means lithium would have been a better choice. And
He has irritability and also euphoria. Both he has euphoria, grandiosity. He has the typical grandiose, elevated thing. Plus also irritability. Both are there.
yes, sir.
So that is one point. Yes. Any other point? And that is a old distinction, not a very well taken nowadays.
Correct.
Even for irritable mania, also lithium still works. Still,
Yes,
it's
sir.
a good option. So because he has not received a trial of lithium over longer period, only first time he got lithium.
Yes, sir.
So in case the gold standard, according to me, lithium is the gold standard. Valproate, not valproate. So
Yes,
many
sir.
times we don't start lithium first episode or second because we don't want to start it and patient suddenly withdraws and rebound mania happening, all kind of uh, complications happening. So we tend to delay starting lithium. But in
Yes,
this case, who is a kind of repeatedly getting attacks and So and depression also, he has depressive episodes also, which can be taken care by lithium in a still better way than
Hmm.
valproate. How about rapid cycling? The concept of rapid cycling here. Will he
Uh,
satisfy for the rapid cycling course?
Sir, more than 4 episodes per year is not had, sir. So rapid cycling, it does not come under. So yes, again, sir, as you told, since it's not rapid cycling, lithium can be a better option. And but also there are things like family history of bipolar disorder, or if the fewer prior episodes of illness is there, then lithium is usually preferred. But as you told, again, it is all older concepts, and lithium is more
Yeah,
preferred.
both. Yeah, both can be. Valproate is also not a bad choice, but we can think over whichever. And another sequence-wise mania depression sequence. First episode, big manic, and later depression came. That favors lithium again
Yes, sir. Hmm.
compared to big M and big depression, small M. That pattern is not very good for. So big
Lithium.
M, uh, then depression. That sequence.
Yes, sir.
It is also useful for lithium. Or even combination also. He is a good candidate for appears to be for prevention because
Hmm.
yearly at least one or two he will get either depression or mania. He can be a good candidate even to give two medicines as preventive
Hmm.
because
Yes,
of
sir.
the heavy load of illness.
Yes, sir.
Yeah, anyone has other points to bring towards management?
Sir, I myself had one question, sir. So recently, lurasidone is found to be good evidence with bipolar depression, sir. But since he had depressive episodes before, I would like to ask you if it's a good choice to start on lurasidone now itself, even though current episode is mania. Is it a good choice for long-term management prospects?
Yeah, in the long term, it's difficult to comment because naturally we won't be having any evidence or anything like that. So, at this manic phase, that may not be very strong enough to take care. Like he
Yes,
required haloperidol, such very strong antipsychotics. So
correct.
that may not serve the adequate purpose, I think, at this time.
Yes, sir. Yes, sir.
So later on, as maintenance, aripiprazole on in the comments, cariprazine also they're talking about. These are for later part and to prevent all those metabolic side effects and other. So we can use aripiprazole in a maintenance phase longer period.
Yes,
Active phase aripiprazole, cariprazine, those may not be very strong to
yes,
give quick benefit. Multiple episode is also a poor prognostic factor. That's what one of the suggestions here. Long-acting injectables also, yes, there is a poor adherence. But apparently, he was taking medicine. Your own presentation says apparently he was taking. That itself is a good prognostic sign. He is responsible and he is taking medicine.
yes, sir. History of compliance itself was
In
also there.
comparison, my own nephew, my own very close relative, he is same, almost same picture,
Hmm.
same repetition of the same pattern exactly. Early onset, all those. His big problem is not taking medicine. Now also, even after several episodes, still he doesn't want to take medicine and want to use drugs and or alcohol. And again, as expected, he's in a rehab center again. So, not taking medicine can be a real negative prognostic thing. So, what about his
These
personality?
patients,
Any
Personality again, sir. The as I mentioned, quick-tempered, history of argumentativeness and truancy stealing, all that would suggest some personality, temperamental issues, sir, per se. Now, personality-wise, we could not assess him after being an adult, and his coping skills, otherwise, and any of the personality domains, like the personality disorder domains, we could not like
likely?
diagnostically,
Yeah, what are the likely possibilities? Whatever
sir.
has been here.
Maybe cluster B only, sir. But
Which
I
one?
don't know which one.
Which one
Uh,
specifically? The dramatic cluster. Which one?
some
I think.
And this patient, according to me, somewhat comes under this uh, this
Dissocial,
borderline
yes,
trait,
because of
uh,
yes,
borderline traits
yeah.
kind of things, both
Yes. So
borderline and
Dissocial.
dissocial.
He has done acts that so earlier somebody asked whether under manic influence he did it or while under remission he was doing. So that
And
distinction is
now
also
on,
important.
and now
So
also he is under remission. Like he used to sit in the uh, this and he used to call other students. You should respect me, and he used to maintain his status. And if
yeah,
he has, if others are not respecting him, he used to think like they
yeah,
should respect me. I have to maintain this. ಹವಾ ಮೇಂಟೈನ್ ಮಾಡ್ಕೊಂಡಿರ್ಬೇಕು,
that yeah.
ಕರೆದ್ಬಿಟ್ಟು ಹವಾ ಮೇಂಟೈನ್ ಮಾಡ್ಕೊಂಡಿದ್ರೆ ಕರೆದ್ಬಿಟ್ಟು ಒಂಥರ ಆವಾಜ್ ಹಾಕ್ದಂಗೆ, ಸ್ವಲ್ಪ ಆವಾಜ್ ಹಾಕ್ದಂಗೆ, ಜಾಸ್ತಿ ಇಲ್ಲ.
So that narcissism, is it related to manic episode or by nature he has that tendency? Let's say
history-wise, yes, sir. In school and all, his behavior, fights and all, may be triggered due to like somebody.
bullying and yeah,
Yes, sir. Could
challenging,
be. So such narcissistic traits might be a possibility, sir.
narcissistic SPD, something called malignant narcissism
Morning.
by Otto Kernberg. So may not be frank, all these disorder in full blown state, but traits of those that line. And many manics will have those narcissistic ASPD traits, narcissism especially.
Yes, sir.
Manic, it's called manic defense.
Yes, sir.
Narcissism is a manic defense.
Narcissism and yes, sir. The social, antisocial things. I don't like. We need to have further clarification and to diagnose under conduct disorder. But yes, sir. Since onset has been before 18 years of age, oppositional or conduct, either one of them is a high possibility.
But main thing is he comes religiously for follow up and he takes medicine. That is the he comes for follow up. That's a
Correct.
good thing.
Yes, sir.
Many these
He's coming
narcissist
for the
SPDs they are highly careless and they don't consider when they are fine, no medicine,
Correct.
nothing. Completely leave it.
he's coming for follow up actually. His
Yeah,
last
it's,
10 days
it's
back only came back.
in the group. There's one question like ICD-11 that effective term is used. Is word effective used in ICD-11? Jay Patak,
Effective means, sir?
student in one of the medical colleges, is
Affecting.
asking. I also don't know frankly. So we are still using ICD-10, and for some time I was using ICD-11, but again here ICD-10 we are using. So okay then. Yeah.
Yes,
So our time is up. Where is our coordinator and from IPS-KC, Dr. Suresh?
Dr. Suresh,
Yes, sir.
15 questions are also there.
Yeah, I thank.
15
Yeah,
questions are also
lot
there.
of learning happened from this case. So I would like to thank Dr. Pradhyumna,
thank
Dr.
you, sir.
Sharanabasappa sir, Dr. Sudhir Hebbar sir for taking out their time to participate in this wonderful program. Uh, Next will be from East Point Medical College. It will be the fifth PG case conference, and it is going to be more fruitful for all the postgraduates. Kindly learn from all these exercises. It will be useful because all the examiners will be the moderators and chairpersons. So it will be more convenient what kind of questions are being asked by the examiners. So it will get oriented from different expertise. So kindly attend and make this event more successful. Thank you once again. Thank you one and all.
Thank you.
Thank you,
Thank you.
Suresh and IPS-KC.
Thank you, sir. Thank you.
Thank you for all of them who attended, and then thank you for giving me this opportunity from IPS-KC side. And I love that my HOD Sharanabasappa sir was moderating this session, and my past HOD Sudhir sir was chairperson of this session. I got to learn a lot from this, and I also hope that others got to learn a lot from this presentation. Definitely, sir, all the mistakes that I've made, I will take into consideration, and I would help. It would help me. Thank you.
Thank you, one and all. Yeah.
Thank you.